So welcome to our second, or actually third, Trauma Anesthesia Society podcast. I'm Joshua Sappenfield. I'm here emceeing with Kevin Blaine. First, I want to again thank our partner, Doc Matters, for hosting our discussion. Thank you for providing us a platform for us to start this new way of distributing information, how we care for the traumatically injured. Second, I want to introduce our panelists in alphabetical order, Drs. Boris Iannatsika, Jerry Jones, and Ram Samet. Dr. Iannatsika is an associate professor in the divisions of acute pain medicine and ambulatory medicine. While he was born in Belarus, he's migrated to the United States, completing a residency and fellowship here at the University of Florida. He's been invited to lecture internationally and nationally. I actually saw him at the ASA annual meeting this year. He also has developed a few patents for ultrasound imaging, simulation, and drug delivery. His interests include education, simulation, and regional anesthesia. Dr. Jerry Jones is assistant professor and division chief of the Regional Anesthesia and Acute Pain Medicine in the Department of Anesthesiology at the University of Tennessee Health Science Center in Memphis, Tennessee. I met him at the ASA annual meeting. He's originally was starting in private practice before spending the last 5 years at UTHSC. He's consulted nationally for industry as a key opinion leader and serves on the committee on regional anesthesia for the ASA and the newsletter committee for the ASRA Society. He also has patented a product and is in the process of setting up a fellowship in regional anesthesia and acute pain medicine for the summer of 2020. Dr. Samet graduated from Yale University of the School of Medicine in 2001, received residency training in anesthesiology at Robert Wood Johnson, UMDNG in New Jersey. He completed a trauma anesthesia fellowship at RM's Cali Shock Trauma Center in Baltimore, Maryland, and subsequently stayed on as faculty. He founded the program in regional anesthesia at the University of Maryland in 2007, and now is the director for Maryland's Acute Pain and Regional Anesthesia Service and Regional Anesthesia Acute Pain Medicine Fellowship. He has authored a couple of review articles on regional anesthesia for the acute trauma patient, and has lectured well over 100 ultrasound-guided regional anesthesia talks and workshops in his career. Thank you all for being willing to talk on our podcast.
Thanks, Josh. So I'll start with the first question. Ron, first off, it's very great to speak with you and to all of our panelists who are so distinguished on this particular topic. Ron, are all rib fractures the same?
Thank you, Kevin. I just want to thank Josh for inviting me to this podcast and really appreciate all the work the Trauma Anesthesia Society does together with Doc Matter on hosting these forums. As for your question, are all rib fractures the same? The short answer is not at all. It's interesting that with more trauma centers and an increasing number of the use of whole body CT scans in these trauma centers after a patient comes in, we're actually picking up a lot more rib fractures that we were missing on chest x-ray. But in many ways, I think we have to think about rib fractures like heart disease. There's so many variations. There's single rib fractures, multiple rib fractures, unilateral, bilateral, sometimes they're flail, non-flail. They could be in all different parts of the thoracic rib cage, anterior, lateral, posterior. Some are hairline fractures, displaced, comminuted. There might be fractures that are non-op and some that require rib plating. You take that's all somewhat in isolation, but many of these patients have concomitant injuries, severe pulmonary contusions, pneumothoraces, hemothoraces, sternal fractures, cardiac contusions, and then how it affects the patients is also quite varied. Some of them are hypoxic, splinting, tachypnic. Some might be ventilated. They may have associated head injuries, spinal injuries, upper abdominal extremity injuries. So there's an entire real gamut of rib fractures that we see in patients that come to trauma centers. Probably about 10 to 15% of patients that come to trauma centers have some kind of rib fracture. And all these variables really make it important that we don't take a cookie cutter approach to analgesic management. We truly evaluate every patient individually to determine what analgesics or techniques will make the most amount of sense, will offer them the greatest benefit with the least amount of harm. So I really try and stay away from grouping rib fractures into one isolated type of symptom.
Thanks, Ron. I think a lot of us in clinical practice would agree with you that rib fractures are very complicated injuries with a lot of components. Jerry, how do you make sense of all of these different types of fractures and how do you sort them out?
Well, I think what Ron said was right on. It's not how many rib fractures do you have and are they anterior or lateral? Okay, this is what I'm going to do. You look at all of these factors, and then you match that up to the particular patient, and look at their coexisting diseases. I mean, their age, do they have COPD, depression, anxiety, some sort of cognitive impairment, their history of opioid exposure. And then what we try to do is we're looking at all of these ribs, or say, which ones matter, not what's your pain score, but we root it in something that's much more objective, like show me how well you can do on the incentive spirometer, or let me see how well you can cough. Which ones are stopping you from coughing? I've seen it lots of times, like Ron said, where you can have one displaced rib fracture on one side, but 4 or 5 on the other. And the thing that the patient complains about is the one rib fracture on the other side. So that's where it's incumbent upon us to get a good history, put everything into context, and then come up with the right plan.
And so I have a question for Jerry. What analgesic modalities are currently being used to treat pain for rib fractures?
Well, there are a lot of options. I'll tell you about our institution. Before our acute pain service started, our surgeons say that they treated patients with a PCA and a prayer. Today, when there are 3 or more rib fractures, or sometimes less, at our institution, that'll prompt an acute pain service consult. And as I explain to patients, we use 2 primary modalities. We look at continuous peripheral nerve blocks and multimodal analgesia. So we look at the patient and determine which continuous peripheral nerve blocks or combinations are appropriate, based on a variety of factors. And then those, once they're in, will infuse for 5 to 7 days, sometimes longer, depending on patient need. And then in the background, we schedule non-opioid analgesics that are ramped up or down as needed. And those typically include, sort of our overall cookie cutter would be acetaminophen, usually IV for 24 or 48 hours, and switch to PO. Non-steroidals, if that's possible, gabapentin. We schedule muscle relaxants, and we also add a sleep aid. When options are limited or they're still having breakthrough pain, sometimes we add other things like Decadron or magnesium or clonidine, or sometimes we'll have to bolus the continuous block with some 0.5% bupivacaine intermittently. And then usually that leaves us where for breakthrough, it's 5 or 10 of oxycodone, maybe 15 if it's a chronic pain patient or some other circumstance. It's unusual for our patients to need IV opioids. That doesn't mean they don't actually receive them for a lot of different reasons. Sometimes instead of a discrete or one of these plain blocks or things that we do, sometimes a rib soaker technique is utilized over a continuous nerve block. We don't have the option right now for ketamine or IV lidocaine infusions or drips as of yet, but those are utilized in a number of places. And then, as you mentioned, thoracic epidurals are also utilized. I think that's a pretty broad view of what's out there.
That is pretty broad. Hey, Boris, is there anything we do here at UF that's different when they do in Tennessee?
No, I think it's pretty much the same. I would say the cornerstone would be regional techniques, would be thoracic epidural if it's a extensive and especially bilateral rib fractures, if we can place thoracic epidural, because there are some situations where we cannot do it because of DVT prophylaxis or hemodynamic instability. The most commonly used block is a continuous thoracic paravertebral nerve blocks, and of course multimodal. So same techniques.
Well, that is a lot of options to put on the table, and I can't wait to see how this discussion evolves. But before we move on there, I'm just kind of curious. Boris, I wonder, how would you decide which patients to treat, particularly treating with a regional block? What criteria would you use? What are you looking for?
Yeah, so I think both Ron and Kevin kind of touched on that. It's mostly individual approach. You have to go and see the patient, and you use both. Patient complaint. Of course, if patient complain on severe pain, it's important to help with pain. But what is frequently omitted, it's actually functional assessment. So some people may say they're pretty comfortable, but if they cannot cough or if they cannot, demonstrate decent numbers on incentive spirometry, we aggressively try to block those people to prevent deterioration, because we usually use this analogy of peach that falls on the ground. So it might look okay today, but if we don't control pain well with all other techniques and all other treatment, they're gonna get worse tomorrow and day after tomorrow. So we try to be a little bit more preemptive, and if patient doesn't show good functional capacity with those rib fractures, even if they say that pain is okay, we try to convince them to get a block. And definitely if they're in severe pain, they're always happy to get a block.
I like your analogy of the peach that falls on the ground and rots later. Ron, I'm wondering, are there any signs or anything that you would look for that would determine or help you predict which patient will decompensate after a rib fracture, particularly when they look good at the start?
That's a great question. A lot of it has to do, first of all, mechanism, right? So is this a blunt injury? Is this a high speed, a high velocity blunt injury, or is it a penetrating injury with some rib fractures? Some of that will suggest that maybe the patient has underlying pulmonary contusions or other intrathoracic complications. And it's important to take that into account, as was mentioned already, as to what exactly the patient is complaining about. And like Jerry said, there may be a patient who has 1 or 2 rib fractures, but is definitely splinting, hypoxic, having trouble taking deep breaths, even with an incentive spirometer and with the various different multimodal agents. And those are the patients we really try and get them over the hill in terms of being able to take deep breaths and get on their way to recovery. It's also, I think, important to consider when you're dealing with a trauma patient and the recognition that there might be multiple associated injuries is, what technique am I going to use that might alter how we'll be able to follow these patients and examine these patients. There are patients who have upper abdominal injuries or intraperitoneal injuries where the surgeons really want to observe them. Are they going to continue to bleed? Are we going to be able to evaluate this patient appropriately, or am I going to mask my exam based on the fact that I now have a thoracic epidural? Similar with spine injuries, you really want to make sure that whatever technique that you use, you're not masking those kind of surgical symptoms that the surgeons might want to continue to follow. And finally, I'd say that there are certain patients that just have incredible side effects from various different multimodal agents. Even patients that are incredibly or exquisitely sensitive to opioids, those are patients that may not warrant a regional technique in certain circumstances, but for them particularly, in order for them to take deep breaths, be able to cough, get rid of their secretions, those are patients that providing a regional technique can be extremely beneficial. But as everyone has said until this point, every patient needs to be evaluated individually.
And I can also add one more kind of like frequent situation. Frequently, patient has a multi-trauma, and if patient is already intubated for any other reason, let's say traumatic brain injury or any other reason, patient is already receiving continuous infusion of fentanyl and propofol or whatever the institution use, we frequently don't rush to place regional techniques on those people and wait when they are ready to be extubated. So we don't place a block, and then kind of block is pretty much, not optimally, time-wise placed, and we don't use it with full advantage. We usually place it right before patient ready to be extubated. So that's another kind of a, common situation with these people.
Well, so Ron, I don't know if the world's turned since I was a fellow. It's been a few years. And I know we performed a lot of thoracic epidurals for rib fractures during my fellowship. And actually, it was really satisfying to see the improvement in incentive spirometry and stuff when we got a nice thoracic epidural working. Are epidurals the gold standard, or are these all other just adjuncts that we do to stuff like epidurals, or are these other modalities just as efficacious?
Yeah, that's a great question. I think anyone who's been following this over the years has seen a dramatic shift, even from the Eastern Association for the Surgery of Trauma, the EAST organization. And you've seen in 2005 when they published some of their initial joint practice guidelines for blunt trauma, they suggested that epidurals were the gold standard and preferred. Over the years, various different meta-analysis, various different studies, and actually more different techniques that are being performed. It seems to be clearer and clearer that there are alternative techniques with less side effects, and in fact, even epidurals themselves are showing sometimes mild or moderate benefits. There are actually some studies that have suggested that there might be some worse outcomes when you look at certain groups with epidurals for rib fractures. So the evidence sort of is going back and forth. Right now, it seems that the most recent EAST guidelines, together with the Trauma Anesthesia Society that was published in the Journal of Trauma and Acute Care Surgery in 2016, seem to just conditionally recommend epidurals. So one has to be really careful as to what benefit you're trying to obtain from your regional technique. Recognize all the side effects that are as a result: your drop in blood pressure, urinary retention, and nausea, pruritus that might be as a result of what's in the epidural solution. And consider what else we have in the arsenal. Paravertebral blocks likely are showing the same efficacy as mentioned before without many of the side effects that you would have in a neuroaxial approach. There are some of these newer blocks, erector spinae blocks, serratus, rhomboid intercostals, regular intercostals. A lot of these are anecdotal, very limited and small studies, but with more training, they might actually be beneficial in certain cases. A lot of these blocks are called paravertebrals by proxy, with the intent of trying to get local anesthetic to spread into the paravertebral space. But often, depending on where the fracture is and whether or not the location of the specific block is going to reach the nerves innervating that location, some of them are just blocking the cutaneous branches and may not offer much analgesia. So you really have to know where the fracture is or where the fractures are and what the objective is, and be able to tailor your local anesthetic and your infusion into the right location. And epidurals aren't always the solution.
Jerry, how about you? Are you a big fan of thoracic epidurals? What's your preferred technique?
I think when we talk about thoracic epidurals, if you want to call them a gold standard, it depends how you're using the phrase. If you're saying a standard by which value or quality is defined, I agree. That is, it's a common familiar reference point. We know its pluses and minuses. If we're saying gold standard means the best and most reliable type of its thing, I completely disagree with that idea. I do think that it's important to keep as many weapons available in the arsenal as possible. And I think thoracic epidurals are a reasonable option for rib fractures in some settings, particularly isolated rib fractures where there's not all these other hemodynamic concerns and spine fractures and other things, particularly for a group who hasn't learned how to perform the ultrasound guided techniques, and those who can perform them with a very low failure rate, because we know that failure rate with thoracic epidurals can be very variable. And that being said, I think since our pain service started in August of 2016, we've only placed 2 thoracic epidurals, and those weren't even for rib fractures. I think thoracic epidurals are effective. Obviously, they're effective, but in my mind, they bring too many drawbacks to use them as a routine in our practice. Like I said, I agree with Ron. The amount of literature that's out there that supports all these other blocks is very minimal right now. But as far as actually doing them all the time, we find them to be very effective, and they help us get around a lot of corners. One of the corners is a lot of times we're sending a lot of patients home with continuous chest wall blocks of various sorts. And presently in my hospital, they can't even leave the ICU with an epidural. So, right off the bat, the utility of an epidural is compromised with our current practice patterns. Another issue is a big issue is positioning. I mean, somebody with 19 broken ribs is not likely to hop up real quick, so let you get a good angle to put those in. And we find a lot of times that we can put people have anterior and lateral fractures. We put in a subpec and a serratus or some other combination or something like that. They don't even have to move. And we've even found that with supine patients, we're able to position them at least well enough that we can put in QLs or ESPs, because you don't really have to get, all the way down somewhere else. You don't have to have their back fully exposed to get to those. And again, mentioning ESPs just briefly, that has been a game changer. A lot of people, they're not comfortable doing thoracic epidurals, or again, a failure rate's an issue, or they're not willing or able to do paravertebral nerve blocks. But an ESP, it's so much easier to perform than these others, and the risk of complications or failure is a lot lower. Using ultrasound with that or with these other blocks, there are clear endpoints for success. And if you look at, for example, ESP, there's about 4 or 5 varieties, retrolaminar and this and that. So they're actually relatively forgiving. If you have a lot of sub-Q air and you can't see, you can just go put it on the lamina and get a reasonable effect. And just overall, like, there are not as many contraindications to some of these other options, like doing them under general anesthesia, or if infection risks, or somebody comes in on Plavix, or it's not uncommon in our institution that everything looks okay, and then 4 hours later they say, oh, actually that was a carotid dissection. They're on IV heparin now. Oh, what if you just put in a thoracic epidural? And then I think being able to, it's convenient for the thoracic epidural to just put in one catheter and run one infusion, but a lot of times ribs aren't bilateral and equal. You have some up high on one side and some down low on the other. And so being able to put in separate, whether it's paravertebral, ESP or something, you don't have as much as a sympathectomy, because you can run one at a lower rate up high, one at a higher rate down low, or something like this. So for me, with all of these options and ways to approach it, for me, the debate about a thoracic epidural as a gold standard for rib fractures completely goes away.
Well, this is an interesting point that we're at, where a common practice that many of us learned for treating the pain associated with a rib fracture, the thoracic epidural, may not be the best option, but we have all of these new blocks that are not all that well tested. So we have to rely a lot on expert opinion and expert experience. Boris, I'm wondering, which of these newer blocks do you like to use? And is there some that you think are more promising or that should be taught more widely?
So probably a wrong person to ask this question. We still kind of let's say heavily rely on thoracic paravertebral catheters for continuous thoracic paravertebral and epidurals if it's bilateral rib fractures. If we can place epidurals, our biggest issue with epidurals actually DVT prophylaxis. All our patients get pretty, aggressive DVT prophylaxis, and if we are consulted a little bit too late and patient already in 11 knocks, we automatically go to paravertebrals. But from new blocks, all these fascial plane blocks, let's say erectospinal block, or serratus plane block, we use them quite sparingly and mostly as a temporization. So let's say like somebody brought up an example when patient is so beaten up that it's very difficult to position, right? So yes, we can do in this situation, let's say serratus plane block. This will relieve pain significantly, and then with some additional, intravenous fentanyl or some other sedation, we can sit this patient up or roll patient on the side, and then place something more definitive and continuous, like paravertebral or epidural. But I, agree that erectospinal block seems to be very attractive from standpoint of, simplicity and minimal risk and kind of a minimal, failure rate. It's probably not as good for some type of rib fractures, like anterior rib fractures compared to paravertebral, but for posterior rib fracture is actually going to work very well, because erector spinae block definitely has a good block of dorsal ramus. And I think it partially is a mechanism goes through this vicious cycle of pain, spasm, pain. If you just relax those muscles, they already feel better. So, like in conclusion, we use fascial plane blocks mostly as a temporization to position patient, and then we go for something that we know and works well for us. It's thoracic vertebral continuous blocks. If it's a bilateral fractures and a multiple level fractures, and patient can get epidural because of no problem with coagulation and no problem with possible profound sympathectomy, then we will do epidurals. And the only thing I can add with paravertebrals, we found recently, we started using those pumps that has a capability of program intermittent bolus, and that's kind of a game changer. If you use PEEB on paravertebrals, the pain control significantly is better, because everyone is familiar. You place paravertebral during this pain consult, and the moment you bolus, patient feels great, patient coughs, patient is grateful, but then the block recedes significantly, and we kind of go, it's still okay, but not as good as during placement itself. With PEEB, we can maintain this kind of a success story for much longer. So that's my answer for new blocks, but some people may use it much more than us, and it will be a better person to answer.
Well, Ron, what do you think? Do you think the erector spinae blocks is the way to go? Do you like paravertebrals? If you had to pick any one of these new blocks that you think is the cutting edge in the way of the future, which one would you pick?
So I think we have to be careful. I mean, we're all regional anesthesiologists. We love doing blocks. We believe what we're doing is great, but the evidence for erector spinae blocks and anecdotally how well they work is very variable. It's variable for many reasons. In the old days when we used to do paravertebral blocks and we didn't get anterior to the transverse process, we didn't get into the paravertebral space, often those blocks would fail. And we'd look at the CTs and see that our catheter was posterior to the transverse process, and we would say, okay, the reason why our patient isn't doing great is because we didn't adequately place this in the paravertebral space. And now we're now transitioning to this mindset that if you put it into the erector spinae plane, which is just posterior to the transverse process, that the local anesthetic will automatically spread into the paravertebral space is not really true. And there's a lot of debates in the literature going back and forth in terms of cadaveric studies, patient studies, volunteer studies with dye, that seem to show conflicting evidence in terms of really how the spread is. If you add that to the fact that many of these patients with posterior rib fractures obviously had trauma to their thoracic wall, it's not so clear that many of the fascial planes that you would presume the local anesthetic to spread through is going to be there, or is going to allow for adequate spread to cover much of the rib fractures that are broken. So I would just exercise caution in terms of how quickly we move to non-neuraxial blocks, fascial plane blocks, with the assumption that they're always going to work. I'd also add that in many ways we do run a fair amount more local anesthetic in much of these fascial plane blocks. They're not sitting directly on a specific nerve or a plexus, but rather in the plane where many of these nerves run. And our objective is to spread enough local anesthetic, cephalad, caudad, medial and lateral. And often, in some ways, we're giving systemic local anesthetic that's being absorbed and might be accomplishing much of what's accomplished with just running an IV lidocaine systemic infusion. I'm not suggesting that you don't see some dermatomal sensory differences after your block, but one sometimes has to think well whether or not the block is directly causing great pain control because it's blocking the nerves, whether or not it's providing a systemic effect. So I happen to be more on the school of thought of going with epidurals, thoracic epidurals for bilateral fractures, but given the caveat that Jerry mentioned, that if you have high rib fractures on one side, low rib fractures on the other side, you'd have to modify, and maybe that would be a time to use some of these fascial plane blocks. In either way, in either case, again, going back to Jerry's initial comments, try and examine the patient, touch the patient, figure out which rib fractures are really causing the pain, have them take a deep breath with an incentive spirometer and sort of see where they splint. And sometimes just attacking some of the rib fractures is more than adequate, together with the multimodal analgesia that we're providing, to get them to where they need to be in terms of tolerating more physical therapy, respiratory therapy, and getting them to breathe adequately to overcome these rib fractures' detriment on their health.
Well, thank you, Ron, and really thank you for explaining a little bit better what a rector spinae block was. I found Boris's answer a little refreshing, because I actually don't know the difference between all these blocks. It almost feels like you need a regional fellowship just to know what the blocks are to put them in the first place. We've already answered a lot of my other questions, like how does one decide on a technique and other important considerations taken into account for doing these blocks. Ron, I was wondering, is there maybe a easier, shorter to remember kind of like rule of thumb? I know there's always an exception to the rule, that to help guide decision making for placing these blocks.
I think first and foremost, everyone should start with multimodal, as mentioned. If patient is a candidate and there's no contraindications to starting acetaminophen, some kind of NSAID, whether it's IV ketorolac or celecoxib orally, maybe ensuring if they can get a gabapentinoid. IV lidocaine, IV ketamine are newer agents that many places are beginning to use. But at the end of the day, if you have a patient who seems to still have respiratory compromise or is having side effects from some of these other modalities, or you're really just trying to get comfortable, you got to go and examine the patient. When you examine the patient, you learn a lot, you hear the history, you really assess the fractures. What I like to do is often to look at the CT scan. And sometimes I go to the radiologist and sit together with them and look exactly which ribs are broken, which ones look like they would contribute to more splinting, more respiratory compromise, identify which ribs of those are fractured and to what extent. Is there a flail segment? And truly target that area. There are individuals who have suggested rib scorings in terms of identifying which patients are more prognostically at an increased risk of decompromising or increased morbidity and mortality. Some individuals use some of those prognosticators and scoring to help them decide which patients to do blocks on. But I think based on what everyone's suggesting is these are so wide ranged and so variable that you just need to go and assess the patient and come up with what makes the most amount of sense for this specific patient.
Well, Jerry, do you have a shorthand form of what is most efficacious in these patients?
Well, I definitely have a longhand form of it, but I'll tell you some of the other comments I'll make in addition to like things that Ron was just saying. I mentioned some of the other factors that we consider when we're choosing one technique or the other. And it's not just, what does it say on the CT, but, examining the patient, figuring out what's going on. But it's also figuring out what's going on with the rest of the of the plan for the patient. So again, like, what are the other injuries? Are they planning to have surgery? Do we believe that the thoracotomy or an X-lap is in their future? Do we think this is likely a rib blading patient? For example, and let me just I've got to add this point on about, what's the best thing to do. And we don't all know, and there's lots of ways to be successful. I think with some of these other blocks, again, the literature doesn't have a lot of information of it, but on them yet. But what we do is very thorough. I mean, every day's progress note will say, if you have a sub-PEC in, they have decreased, temperature sensation from T2 to T6 to the nipple line. Patient able, you have to make sure that what you've done actually works. So you have to, absolutely follow that up. Make sure that you're doing the techniques appropriately. But I would look at other things like, say somebody's got a liver lac or something they're watching very closely. So if they have posterior rib fracture, or let's just say that they're lateral, I might consider a serratus if that's one, or an SIFB. But if I think there's a reasonable chance that they're going to get an XLAP, I might go ahead and do a paravertebral or whatever it is, knowing that that nerve block may serve a double duty if they, do an XLAP. Or if I do have several catheters that might be running or that might end up in that position, and look, oh, they also have, an amputation below the knee on the left. Well, I can only run so many catheters on anything about that. And then looking at the patient themselves, so what does their body habitus tell you is going to be easy or difficult? Or is sub-Q air going to get in the way of a paravertebral, or whatever, a serratus or a subpec or something like that. And then looking at, if someone who's really needs help, but they're also about to go back to the OR for something else, that may be the other thing that allows me to position them better to give me more options. And then, your overall skill level and experience, that might tell you right there if you're going to do a thoracic epidural or a paravertebral or an ESP or one of these other things. I think you should also consider the resources and infrastructure in your hospital, because if you do a thoracic epidural, most people have an idea what that means. That automatically makes them think of certain protocols and things that they do. But the nurses may not really understand with some of the other nerve blocks. Oh, is this going to make them a fall risk if they did this? Or do we have to worry about DVT prophylaxis? Or the surgeon's worried that maybe you're going to mask something, or we kind of ran into this with our neurosurgeons when people had spine injuries and we put local anesthetics in an ESP space or something like this. So ultimately, it's about these relationships with the other people around you. I think that really is going to tell you what the right thing to do is for now. With my skill in my institution and my colleagues, this is where we are right now. So I think ultimately you can be successful doing it a lot of different ways.
Does anyone have any closing remarks that they would like to make or clarify about the available analgesic modalities for rib fracture pain?
I think maybe just a couple of comments, because from a standpoint of fascial plane blocks, some of them, especially on the trauma patients, would be probably most of the time single injection blocks, and just have to understand that single injection block will have a limited duration. So that's why frequently we go to something that is, time tested, like continuous paravertebral epidurals, because it gives you nice catheters for several days. So that's kind of important, because it will be limited benefit if you do block. It definitely helps patient, but then 6 hours later patient back where patient was. So some, like for example, serratus plane will work for some fractures, but sometimes it's difficult to place a catheter there, and so I think that's kind of important. And another question about trauma patients, because it's a continuous, like a block box, and its diagnosis is evolving, and several teams are involved in treatment and management of a patient. Sometimes it is important to kind of look forward and see what can happen. Like somebody mentioned, is there a chance for additional surgeries or additional workup? So some of our catheters, for example, in our institutions, they're wire reinforced, so they're not compatible with MRI. So I always kind of trying to see what is the chance that patient will have a additional MRI, because then we're going to get a phone call, say like, hey, you have to pull your catheters because we're playing in MRI. So then I will place different catheters, for example. So it's another little comment. But otherwise, it looks like a great discussion, and everyone has plenty of experience because it covers multiple points.
If I might just follow up with Boris's comment, I think as we do more and more, we definitely need to have more coordinated, multidisciplinary teamwork. There's no doubt in our institution as well, we might put in a fascial plane block, but even if the computer may or may not have that option, many of the nurses just assume if there's a catheter that might in the back, it's probably an epidural, when it may not be. And that obviously can change and modify the way they administer anticoagulation or get the patient up or take the Foley out. All of those things do become a factor. So it's really critical to educate everybody, to have everyone on board, the trauma team, APMS, respiratory therapy, physical therapy, nutrition. They should all have some of the same goals. And the more you can protocolize things within your institution, obviously the better it is. And just keeping appropriate vigilance in terms of not only when you put the catheter in, but following it for the next couple of days, as was mentioned.
Yeah, I'll just make one quick point. Exactly. If you did any of these blocks as single injection, they're almost probably not worth doing. And multimodal is a significant advantage. So, so again, when I talk about using all of these subpec, serratus, ESP, any of these things, all of them for rib fractures they're all catheters. So the only time we do it as a single shot is if you like to say if we're going to temporize someone so they can sit up and get in another position. But no, I agree. I think we covered a lot of ground with this and talked about a lot of different ways to do it. And I think a lot of the essential elements that are going to lead to success or lots of troubles if you don't do it that way.
Well, this concludes our third podcast for the Trauma Anesthesia Society. Thanks again to our panelists for your time. It was a pleasure discussing this topic with you. If any of our listeners have any questions or comments about discussion, feel free to leave a comment down below. We will try to address these in a timely fashion.